All right, let's go ahead and get started. Again, thanks y'all for being here. We are very excited to have two of our own Emory physicians presenting this week at Emory Department of Medicine Grand Rounds. Dr. Swenson is an associate professor of medicine and the director of the Bronchiectasis and Non-Tuberculous Mycobacterial Lung Disease Program here at Emory in Atlanta. Additionally, he's the section chief of Pulmonary and Critical Care Medicine at Emory St. Joe's campus and the chief of medicine for the hospital. His research interests include infectious pulmonary diseases, particularly non-tuberculous mycobacterial disease, and clinical outcomes in patients with bronchiectasis and non-tuberculous mycobacterial pulmonary disease. He's the PI on numerous clinical trials evaluating novel treatments for bronchiectasis and non-tuberculous mycobacterial lung disease, and directs both the Bronchiectasis Research Education and Therapeutics Initiative and the Bronchiectasis Biorepository and Data Warehouse Exchange here at Emory. He's published articles on topics such as non-tuberculous mycobacterial pulmonary infections, the recognition and treatment of bronchiectasis, and the treatment of eosinophilic asthma. He's the associate editor of chest infections for the Journal of Chest, Pulmonary, and frequently lectures on the diagnosis and treatment of non-tuberculous mycobacterial pulmonary disease and bronchiectasis. Dr. Abdallah is an assistant professor of medicine in the Division of Infectious Diseases here at Emory in Atlanta. His clinical and research work focuses on tuberculosis, non-tuberculous mycobacteria, and the epidemiology and pathogenesis of mycobacterial diseases as part of the Emory Bronchiectasis and Non-Tuberculous Mycobacterial Program. In addition to his academic work, he serves as a medical consultant for the Georgia Department of Health tuberculosis program, where he advises clinicians across the state on complex TB cases, including drug-resistant and extrapulmonary disease. His research has also contributed to international efforts with the WHO to better understand the intersection between tuberculosis and chronic conditions such as diabetes, as well as the epigenetic changes of tuberculosis infection through an NIH-funded pilot grant with the Emory and Georgia TB Research Advancement Center. He completed his residency at Indiana University School of Medicine, where he served as chief resident and his infectious disease fellowship here at Emory before joining us on faculty, and has also completed a Master of Science in Clinical Research at the Emory Laney Graduate School. Thank you both so much for being here today.
Thank you so much, Annie. And I absolutely love your background pictures. I feel like there's a story there, and you'll have to tell tell us all about it. But that's a whole other Grand Rounds presentation. All right, let's see here. Sorry. Okay, great. I hope everybody can see the screen.
We can.
Okay, wonderful. Great. Okay. So Wassim and I are super excited to be here today to present our work together in building a collaborative pulmonary and
Dr. Abdallah and Dr. Swenson, I think your connection may have been interrupted. Yes. We still see your slides if you can hear us, but we cannot see your camera cut off and we don't hear you. Seems like their connection cut out. We will have them rejoin us. Thanks y'all for your patience. Kim, they're back. Can you make them co-host again, please?
Yes.
It should be. Yes, Dr. Abdallah, Kim is working on making you co-host so we can see.
Oh, it's not working.
Okay, sorry. Right. Okay, let's try that.
Wonderful video.
Okay, cool. All right, and
Sorry
then
about that, guy.
no, we're not really a Zoom, it's
What
a
can you
technical
say?
hiccup. Let's go ahead and have you
Yeah,
slides.
yeah. Okay. Like this. Okay. All right. Can you see the screen well?
Yes.
Perfect. Okay. Let's see here. Is everybody able to see the screen?
We can see your slides.
Okay. Perfect. That's great. Okay, good. So again, apologies for the technical difficulty. For some reason, the Emory computer decided to reset itself. So which can happen unexpectedly. But just some background on the bronchiectasis and NTM program here at Emory. So I started the program all the way back in 2016. So we're roughly 10 years old at this point. And the reason I was excited to do the grand rounds with Wassim today is just sort of how organically the program has grown from a pulmonary sort of only program with really just sort of founded with my interest in two neglected disease states to really a multidisciplinary clinic that involves, of course, patient care as its guiding principle and paramount, but also collaborative clinical research and translational research as well. Wasim joined the program about a year ago. He became very interested through his TB work in non-tuberculous mycobacterial infection. And Emory is a wonderful place to collaborate those sort of collaborations. And so as a fellow, he asked to come to clinic, do some rotations, and of course got bit by the NTM bug, and here we are. So our current program, the BREATHE program, which stands for Bronchiectasis Research, Education, Advocacy, and Therapeutic Development at Emory, really strives to achieve sort of the tripartite mission of Emory, which is, patient care, research, and of course, educating our next generation of trainees. And so we currently care for about 650 patients across mostly Georgia, but also the Southeast in general. These are my disclosures today. I'm PI on a number of industry-sponsored trials as well as investigator initiated trials. I also serve as a consultant to Insmed, Boehringer, Ingelheim, Baxter, and Inogen. Both of those are device. Dr. Abdallah is a sub-investigator on a number of industry sponsored trials, as well as our clofazimine multi-patient protocol, which some of you may be familiar with and we'll discuss a little bit more. Our learning objectives today are really to recognize the signs and symptoms of bronchiectasis and non-tuberculous mycobacterial lung disease, describe certain host traits and susceptibility factors with bronchiectasis and also NTM lung disease, to summarize the treatment guidelines, and also just sort of compare existing and emerging treatments for both bronchiectasis and NTM lung disease. I think you'll see as we go along in these cases that there's incredible overlap between these two disease states. It's very difficult to completely separate them. And with that, I'm going to hand it over to my colleague, Wassim.
Thank you, Colin. Starting with a case, a 77-year-old female who has hypothyroidism, paroxysmal AFib, GERD, recurrent rhinosinusitis, is referred to our clinic for a tree and bud nodularity in the right middle lobe and lingula, with one acid-fast bacillus sputum culture growing Mycobacterium intracellularly. Previously treated for MAC pulmonary disease in 2018 and 2019 for 9 months. Her symptoms now are daily cough for around 3 months, dyspnea on exertion, increased fatigue, and 8-pound weight loss. She says, I feel okay most days. I really don't want to go back on those meds. Keep hearing that all the time.
Yes, very familiar refrain.
Her vital signs overall, I would say unremarkable except for a mildly decreased oxygen saturation, 94%, and a BMI of 17.8, kind of typical also of the patients we see in our clinic. She is on sotalol, levothyroxine, apixaban. She is on a breast tree inhaler, nasal fluticasone daily, omeprazole, and denosumab every 6 months. Her white blood cell count is 11.8, and her sputum AFB culture says rare AFB on smear and a culture positive for Mycobacterium intracellulare. So now I'm going to hand it back to Colin to see how he approaches imaging when it comes to these patients that get referred frequently to our clinic.
So I think this is a great illustration of sort of the prototypical nodular bronchiectatic phenotype. We used to refer to these patients as the so-called Lady Windermere syndrome. We do not use that nomenclature anymore for a number of reasons. Paramount is just that it's very inaccurate to describe this patient population. But what I see in this CT is sort of the typical findings of right middle lobe and upper lobe predominant bronchiectasis. And I'll talk a little bit about what that bronchiectasis is. You can see that there is a lot of atelectasis in that right middle lobe, and also tree and bud nodularity over on the left, as well as areas of nodularity in the right lower lobe and sort of the dependent portion as well. You can see this patient also, we don't have the mediastinal windows, but there is also sort of the impression of some sarcopenia as well and some nutritional loss.
Perfect. So let's start with kind of more basics and say, what are NTM? Because a lot of people don't see that frequently. So an NTM is really non-tuberculous mycobacteria. We have now over 200 NTM species that were identified by 16S sequencing. Their pathogenicity is considered limited when it's compared to TB, for example. They are environmentally ubiquitous, and their potential routes of transmissions are usually freshwater, soil, and then supine aspiration from the stomach when the food or the water contains that NTM and it was ingested. The classification of NTM can be classified in different ways. One of the most common ones is the speed of growth on solid media. So in general, we say in a subculture on a solid media, if it grows in less than 7 days, we call those rapid growing non-tuberculous mycobacteria. And the main examples of pathogens that we see in human disease are Mycobacterium abscessus, Mycobacterium fortuitum, and Mycobacterium chelonae. And if it grows in more than 7 days, then we go to MAC, which is, don't forget, is a Mycobacterium avium complex. So it's a complex comprised of multiple mycobacteria, including Mycobacterium intracellulare that our patient has. But also we have the close cousin of TB, Mycobacterium kansasii, and Mycobacterium zenopi that we see frequently in our neighbors on the northern border, Canada. So NTM are intracellular bacteria. They have lipoarabinomannan in their cell wall that inhibits phagolysosome fusion. It inactivates TNF-alpha IL-12 to evade immunity. It's thick, waxy cell wall rich in mycolic acids that we talked about. It's hardy. It resists acids, alkalis, detergents, and oxidative burst. And when you say hardy, it's resistant to heat, to up to 52 degrees Celsius and a pH as low as 2.2. And even though we think about them as part of like water systems, they are really significantly hydrophobic. And actually, even though that's not, this is a bit counterintuitive for most of us, but it actually, this hydrophobic nature of it allows it to form these biofilms in water surfaces that allows it then to be resistant and hardy as we described.
Julie, I should also mention that we say slow grower and rapid grower, but the truth is that mycobacteria, because of all of these virulence factors, are really slow growing compared to regular bacteria. Right. And that also is a sort of a resistance and survival mechanism. It just becomes very difficult to kill these bugs when they grow so slowly.
Right, 100%. Thank you, Colin. Yes, I agree 100%. So these, and not all NTMs are the same, right? So we have, we can go in this triangle that we see here, and the lowest at the base of it, we're describing the always a pathogen. So whenever we see TB, most of the time, whenever we see Kansasii, we say, okay, this is a real pathogen. And whenever we see Mycobacterium gordoniae, we think of it as like unlikely to be the cause of the disease. And then you have in between the others, including MAC, which is kind of like a 50-50 one and around it. But another very important aspect of it is not just the name or what is the pathogen, but how many times did it grow? If somebody is presenting with nodules in their lungs and presentation with clinical presentation consistent with non-tuberculous mycobacterial pulmonary disease, and they grew Mycobacterium gordoniae 7 times, they're basically trying to tell us something that maybe it is Mycobacterium gordoniae. So never ignore a pathogen, but it helps us usually in the initial assessment of patients and kind of stratify the risk.
I completely agree with you, by the way. And we get referrals quite a bit for Mycobacterium gordoniae to clinic. If it's only one isolate, we typically say, okay, this is not anything we typically need to worry about. But like you said, if we see it 2-3 times, and we have had those patients, a couple of them, we tend to take it more seriously. Oh, this is my cue to talk about prevalence.
Yes.
Okay, we can't have this conversation without talking about incidence and prevalence, and both are increasing in the United States. So this trend, by the way, that you're seeing here of about 8% increase per year combined in the Medicare population continues to be the case on more recent data published through 2015 and beyond. And this is not just important in the United States. This is an international phenomenon. So data published by the European cohort, by the Australian cohort, gives a very, very similar picture. We know that there are roughly 100,000 cases. We think that that's quite underestimated in the US. It tends to affect women more than men. It tends to affect white and Asian women more than people of color historically. But we think that some of that is simply due to care bias and reporting bias. We're seeing now, as data is coming online from some of our safety net hospitals, from some of our rural hospitals, as we really grow the US bronchiectasis research repository, it's really something that is on the rise across all populations. This is also data from the US Medicare population, and you can see that it really, the prevalence is highest sort of in these coastal states. It's most endemic in Hawaii, and there are a number of reasons for that that sort of are beyond the topics of this grand rounds, but always happy to talk about that offline. But it's also quite high in the Gulf Strait region, but these are outliers. There are a number of associations, including population density, surface fresh water, higher precipitation, daily evapotranspiration, which for those of you who don't know, I did not know, is sort of the sum of surface water evaporation and also transpiration from plant material, lower elevation, and a municipal water supply. Now, the last sort of led to a couple of different theories or hypotheses, including could there be trace metals, or could there be disinfectants, or could there be some sort of pollution in these municipal water supplies that are leading to the increases. And in fact, very recent data published by the NIH shows that in certain areas, certain regions, for instance, the West, the South, and the Northeast, in fact, trace metals do contribute, or at least are correlated with an increased risk of developing NTM infection, either MAC or MABs. The ones of particular interest, of course, are vanadium, as you can see here, and molybdenum on the West Coast. And that's also the case in Hawaii, where molybdenum is rather high. So this here is data that was published about 4 years ago by Joe Falkingham that looked at NTM. This is more of the granular exposure analysis, but this study looked at 31 patients with NTM lung disease and tried to match samples collected from their household plumbing, faucets, shower heads, bathtubs, etc., in their homes, and compared it with the patient's clinical isolate. And what they found is that in almost 50% of the samples, it actually matched the patient samples, the index patient living in the home. And in 41% of those cases, the organism from the home and the patient were exactly the same using a DNA analysis. So again, pretty compelling story that there are environmental exposures here that all of us are exposed to. We can't ignore it. Now, why some people end up developing it and others do not is a question for another day. So I'm going to turn this back over to Wassim to answer this important question. Does our patient have MAC-PD per the guidelines requiring treatment?
Yeah, thank you, Colin. This is the eternal question that we really ask ourselves every time we see a patient. And I'm happy if anyone wants, like in the chat, to like put in their thoughts or like unmute themselves. Feel free, obviously, to do that and give us your thoughts. But if not, this is really the question that it's not an easy question. It's one of the hardest questions that we have to ask ourselves every time in order to decide. And so how do we decide? One is there are guidelines that were published by the IDSA and ATS in 2020, and that really talk about the criteria for diagnosis and treatment. So really, what are the cases where NTM pulmonary disease needs to be treated, not just have it, but needs to be treated. So it's a combination of three parts. The first one of them is the patient has to have symptoms. They can be pulmonary or systemic, but they have to have symptoms. They cannot be a completely asymptomatic patient. If they are, then these patients do not usually qualify for treatment for NTM pulmonary disease. And if they have symptoms, those symptoms should not be caused by another alternative explanation. The second thing is the radiographic part of it. So the person cannot have NTM pulmonary disease with a completely normal CT scan of the chest. So the CT scan of the chest has to have findings or changes that could fit with the patterns that we usually see in NTM pulmonary disease, including nodular disease, cavitary disease, and especially tree and bud pattern that we see. And then the third part is really the microbiologic evidence. So we get a lot of consults for patients who get sent to us because their CT scan is consistent with NTM, but we really need to confirm that with microbiologic evidence before deciding to treat. So the first one is, because we talked about the fact that NTM are not always pathogens like TB, where if you find TB once, that's it, you want to treat it. To increase the chances of this being a real pathogen, we rely on it growing more than one time in sputum culture. So at least twice, if it's a regular sputum culture or induced, or it could be from a BAL only one time, or from a biopsy from the lung, one time is enough. But if we're just getting expectorated or induced sputa, then we have to rely on more than one positive culture. Now, the problem is a lot of times our patients have maybe a little bit of symptoms, maybe a little bit of radiographic changes. They were able to give a one-time sputum and they could not give more.
Or they underestimate their symptoms.
Oh, they underestimate.
They go on treatment.
Right, and the symptoms are chronic, so they kind of like chronic anemia kind of situation where people don't realize their symptoms. So there are studies that were done, and this is a force plot by Dr. Wang and et al. In 2023 was published to look at who are the people who are more at risk of having a progression of their disease. And this specific force plot is for radiographic progression. And it has shown that people who have a consolidative pattern in their disease, not just tree and bud nodularity, those who have leukocytosis, those who have a cavitary disease, not surprising, and elderly people had significantly more risk of progression of their disease, and so kind of logically more likely to benefit from initiation of treatment. Also, AFB, smear positivity, history of TB, and mycobacterium abscesses tend to have more also risk, even though it was not shown to be significant in this specific meta-analysis. So, NTM, lung disease, is a chronic disease. So kind of I want people to answer, and then we'll see what Dr. Swenson has to say. But NTM, lung disease, is a chronic disease that, while debilitating, is not associated really with any increase in mortality. Any thoughts from the crowd? And if not,
we'll give him a second.
Yeah,
we'll give him a second just to ponder that. But my answer is very firmly false. And we know this actually through sort of meta-analyses and through population studies looking at non-tuberculous mycobacterial disease in the United States, which shows that there's a 27% 5-year all-cause increase in mortality. So this is not, it's not something that is to be taken lightly. It tends to progress over years, sometimes over decades. And so sometimes it's easy to lose sight of those numbers, but it's associated with not only increase in mortality, but also increase in morbidity. So chronic symptoms and periodic exacerbations as well, increased hospitalizations, worsening PFTs, certainly radiographic deterioration, and more importantly, just sort of as an umbrella, just an impaired quality of life that we see with these folks. So in our case, we're sort of left with an elderly patient who is symptomatic. She has a low BMI. She has mild leukocytosis, which you mentioned is one of the predictors of radiographic progression. And more importantly, she's got 2 positive AFB cultures. One of them is smear positive. So what does that tell you, Wassim?
Yeah, so kind of like going back to the evidence that we have in terms of like who are the patients who are at risk of progression. This patient fits with a lot of these with impaired, kind of being symptomatic, having an impaired quality of life because of those symptoms. But the fact that the smear is positive, that tells us that the kind of the load, the mycobacterial load, is high enough that these patients, we tend to approach them as real and as more likely to benefit from therapy initiation if possible.
Yes. And it should be said, early initiation of treatment. So we know that if they're smear positive, like you said, there's a high bacillary burden. These patients are extremely high risk of progression. So we generally take that seriously.
Yeah. So what else should we address? Because the problem with this, whenever we see these patients is, the decision after going this eternal question of like, do they even need treatment? But once we get to the decision of treating, it's not easy, right?
No.
And so what else do we need to address before starting treatment?
So there are still a number of things that we do need to address, that I would want to address before initiating antibiotic treatment. So I always like to say that a decision not to treat with antibiotics is still a treatment decision. And just because we don't treat with antibiotics, we still have other tricks up our sleeves. I would argue in this case, the smear positive patient, we probably would want to talk more seriously about antibiotics. But specifically, before we rush there, we have a couple of questions we want to answer, such as, do we have drug susceptibility testing for this patient? Was the isolate sent out to a reference lab like National Jewish in Denver, Colorado, for macrolide and amikacin susceptibility? That's super important. Also, has the patient even been told that she has bronchiectasis? And if so, was she educated on it? That's also super important to know. She's on medications that have significant interactions to any proposed regimen that we would come up with. We'll need to make sure that she's established and she's regularly seeing her ophthalmologist. We also will want an EKG if one hasn't been done in the last 30 days because of the risk for QT prolongation. Also, with these patients, we always want to have pulmonary function testing, or at least spirometry, because as we start thinking about inhaled therapies such as inhaled amikacin, If they have a very low FEV1, that can aggravate their pulmonary function. So these are all things that we need to keep in mind, Wassim.
Perfect. Thank you, Colin. So let's go through the ENTM identification and how it works in Emory Healthcare specifically here. So all of us get frustrated because the E. coli susceptibilities are not back within 48 hours. Well, here, welcome to the patients of waiting for NTM identification and then susceptibility specifically. So usually the culture at Emory Healthcare and at Grady, they would give us using MALDI-TOF, they will try to give us what mycobacteria is growing specifically. Is it MAC? Is it abscessus? Is it Kansasii? So that information, we get it relatively quickly in comparison to the susceptibilities. Still takes a couple of weeks sometimes, but we get that. But then MALDI-TOF cannot give us a lot more information. It doesn't give us any information about susceptibilities. And also within Mycobacterium avium complex, it cannot really differentiate which one of them, or it sometimes can fail to differentiate between them. So what we do at Emory Healthcare is we send these cultures whenever it's like a first-time growth of a kind of mycobacteria, we send it to National Jewish in Denver, Colorado. And then what they do there is they do initially an identification of the bacteria to tell us which specific subspecies is growing there. And that's using a line probe assay. They also kind of like a PCR or molecular testing. And then they do also quickly, along with that, whenever it's MAC, they do testing for the RRL gene and then RRS genes. And then what we want is not to have mutations, because if there are mutations there, then we would predict for the RRL that would be resistance to macrolides, and then RRS resistance to aminoglycosides. And so that's the initial information that is tested. And then after that, they do broth microdilution methods to give us susceptibilities. Mm-hmm. And here, as an ID physician, the ID inside of me kind of struggles not to look at all of the MICs.
Which you don't, you're not supposed to.
Yes. Yeah. So exactly. So because one is most MICs are non-interpretable. So you can see here the NI. But two is because even for most of them, whenever it's even interpretable, we don't know if using that in opposition to using ones that are resistant or non-interpretable, if there's any really benefit or superiority of doing those methods. Though we do know, based on the guidelines, that we have 3 lines here where it matters. And so the first one I would mention is the clarithromycin, which is a surrogate for azithromycin. And this one, you want the MIC to be low. And if the MIC is low or less than 8, then you can use it, and you should use it in the treatment of MAC. And then the second one to look at is amikacin. And for amikacin, in the specific situation of MAC, including Mycobacterium intracellulare, you want to look at the susceptibility and look at it for IV and also for the inhaled one, because it can be intermediate at 32 or at the 64 for IV, but it can still be susceptible considered for an inhaled amikacin. So if they are susceptible for both of those, then you should use both of those if there's clinical indication. So in the case of amikacin, it would be more for fibrocavitary disease rather than ulcerative disease. Anyway, not saying that you should never look at the others, but I would say that we don't have evidence except for the ones in those green areas to know what to use.
It should also be mentioned that you never give azithromycin by itself.
Right.
So you'd always want to do it. I'm sure you'll talk about this in a later slide, with ethambutol and probably a rifamycin as well, as we'll discuss. And that's to prevent resistance formation.
Correct. NTM disease, similar to TB, should never be treated with a single agent. That should never happen. And then here, just showing you this slide, kind of repeating, but here showing only the ones where we do have interpretable MICs, but to show you also that in rapidly growing mycobacteria, in comparison to MAC, including Mycobacterium abscessus, the cutoff for MIC is different than the cutoff that we see for MAC. So just keep that in mind. An MIC for MAC does not mean the same thing as an MIC for other mycobacteria. So what are the challenges of this therapy? So we have this patient who is on Synthroid, who is on apixaban, who is on Sololol, and who is going to be on treatment for MAC, most likely needs to be on rifamycin per the guidelines. Yeah. So there
certainly azithromycin.
Right. Yeah. And so the risk is, obviously that we will have drug-drug interactions. Yeah. That's the number one problem that we deal with. Two is, as Colin said, getting QTC to make sure that because they're going to be on multiple medications that prolong QTC. Three, these patients develop hepatotoxicity with amikacin, renal toxicity. And then with amikacin and macrolides, the risk is for ototoxicity. So a lot of challenges for therapy. And that's the main reason why not everyone gets treated. Because, you would argue that we were under treating, but the main reason is because of this risk benefit and kind of like the do no harm principle.
I'll probably discuss this, just put on my pulmonary hat.
Yes.
But I'll talk just a little quickly about bronchiectasis. So this patient does have bronchiectasis. You can see it. It was varicoid, so pretty significant in that right middle lobe. Elsewhere in the CT, there were also pockets of significant bronchiectasis. So when I approached this patient in clinic, the first thing was to educate her about her bronchiectasis. She had not heard that term before. She had been told that she had asthma. She had been told that she had COPD, even though she had never smoked. But in fact, she had bronchiectasis. So bronchiectasis education, and also we would want to do an etiologic or a reason for her to have bronchiectasis, an etiology investigation, and we'll talk about what that is. She's on a number of contraindicated medications, or medications that can actually do harm with both the bronchiectasis and NTM we'll talk about. She needs to be educated on airway clearance techniques, so a way to improve her mucociliary clearance to keep the airways as clean as possible. There's also medical therapies to talk about. We have newer medical therapies for bronchiectasis that we would want to discuss, and adjunctive therapies as well. So again, it's not just a kind of a one-size-fits-all. In terms of bronchiectasis, I realize some viewers or listeners may not know what bronchiectasis is. So I'm just going to give you a very simple definition. It's permanent enlargement of the bronchi where the internal diameter of the bronchi is larger than the accompanying artery. So usually that ratio is around 1.5 or greater. It's the so-called signet sign, the signet ring sign, where the signet portion of the ring is the artery and the ring portion is the bronchus. So if you just sort of keep that in mind conceptually. There are caveats. So people who live at very high altitude have narrowing of their pulmonary vasculature, which can actually make the airways appear artificially enlarged. This is just a nice radiographic presentation of a patient with bronchiectasis, not our particular patient. But you can see in A, there's an area of cystic bronchiectasis. So that is a dilated airway with airway thickening, probably with chronic infection living there. B is an area of cylindrical bronchiectasis, and you can see that there's lack of tapering. There's also visibility of the airway within 15 millimeters of the pleural surface. D is a mucus plug that's actually just sitting in the airway. We see this quite a bit with these patients. And then, of course, C is the signet ring sign, signet ring sign. So again, enlarged airway with the signet portion being the pulmonary artery. So in terms of epidemiology, sort of very similar to NTM, we know that this is increasing worldwide. There's a 40% increase over the last 10 years in the US alone. It parallels the increase in non-tuberculous mycobacterial disease. It tends to peak in the 7th to 8th decade of life. Again, it tends to be higher in women of Caucasian and Asian descent. But again, this is highly subject to bias. And there are diverse etiologies. It's a heterogeneous condition. So unlike, say, cystic fibrosis, where you have one protein mutated that results in mucociliary clearance deficits Here you have a variety of etiologies, and sometimes the etiology can be elusive in roughly 40% of the cases. We can't talk about bronchiectasis without broaching the basic pathophysiology in sort of embodied by the vicious vortex model. So you can see in this model, I realize it's busy, but there are four key disease domains, and they can affect one another bidirectionally. So those domains are airway dysfunction in blue, inflammatory response in sort of the pinkish red, structural lung disease in purple, and then in green, chronic infection. So those are the sort of four domains, and each one can affect the other. For instance, for decades, we have been anchored on just the airway dysfunction domain, prescribing hypertonic sodium chloride, various devices in order to improve mucociliary clearance. We've also been prescribing antibiotics routinely, sometimes multiple times per year for these infectious exacerbations. And unfortunately, that has led to multi-drug resistant organisms, or at least it carries that risk. So this vortex model explains why targeting just a single domain only has modest effects on overall outcomes. And it really argues for multimodality treatments that are targeted as much as possible to the domains of the disease and treatable traits. We're now getting a much clearer picture of, as we talk about sort of the airway dysfunction domain, much clearer picture of CFTR dysfunction. So this is the CFTR protein, and this can be either innate or it can be acquired just through multiple hits hypothesis as these patients get older. We're also improving our diagnosis of PCD. This is primary ciliary dyskinesia, a very often overlooked etiology of bronchiectasis, and chronic sinusitis as well as infertility. So, and we're working on treatments targeting that particular disease state. We're also understanding more about sort of the cellular components involved or the inflammatory response involved in bronchiectasis, in particular, the role of neutrophils, and in particular, the role of neutrophil serine proteases and the destruction wrought by neutrophil migration from the blood to the airway lumen and the evolution of bronchiectasis across the lifespan. This is something that we're actually working on here at Emory with our Department of Pediatrics colleagues, and we're super excited to study more about on that front. And then, we've long understood that inflammation is often driven or preceded by infection with particular pathogens of interest. That includes NTM, like we're talking about, but also Pseudomonas aeruginosa. We know that patients with bronchiectasis who are chronically colonized with Pseudomonas aeruginosa tend to be far more exacerbation prone over their lifetime. In terms of non-CF bronchiectasis, it is really, truly a coat of many colors. It's mechanistically heterogeneous. It's really shown, I think, in this color wheel that was published by the European cohort EMBARK. While bronchiectasis is clinically, radiographically, and pathophysiologically similar to CF, it is not cystic fibrosis. Bronchiectasis, by definition, is a single organ disease, while CF affects multiple target organ systems. One of them, of course, is the airway, and that in turn results in bronchiectasis. But in reality, we have many underlying diseases that may result in bronchiectasis. And in fact, it's one of the reasons that we're getting away from calling it non-CF bronchiectasis. We're adopting sort of a one bronchiectasis sort of framework. So when to consider the diagnosis in this patient: chronic cough with sputum production, recurrent infections, gram-negative rods or NTM in the sputum is a huge red flag. If you have patients who are getting pneumonias year after year after year, especially multiple times per year, please evaluate them for bronchiectasis. If you have difficult to treat asthma or COPD, especially if there's COPD in a non-smoker, again, huge red flag. Again, and try not to prescribe medications that could actually make a bad situation worse. And lastly, if the patient has hemoptysis, huge, no pun intended, red flag. So usually hemoptysis does not just occur out of nowhere. Sure, it can be related to epistaxis, but if it's recurrent, evaluate the patient for bronchiectasis. This is just a sort of a general slide for etiology testing that we run in our program. And it can help us determine the etiology in roughly 40% of the 40 to 65% of the cases, but it can directly affect the management of the bronchiectasis in about 40% of cases.
Yeah, and we've diagnosed people with cystic fibrosis at the age of 60 and 70 sometimes.
Absolutely.
Who had mutations that just allowed them not to be very severe throughout their life, but went undiagnosed, and their lives changed after the workup that we started.
Completely life-changing for those patients getting an accurate diagnosis. We also have patients who have hypogammaglobulinemia and recurring infections, and getting them on replacement can really be a game changer. So as we talk about sort of the barriers, to treatment, getting back to our case, there are a number that I see. One of course is airway clearance education. One of them is potentially harmful medications. The other one is interactions, which you covered beautifully. And then her own anticipation and anxiety about going back on these medications. And lastly, of course, her low BMI and nutritional status. This is data out of the Canadian cohort of about 3,000 patients prescribed inhaled corticosteroids. And what they found is that, there is a significant correlation between the dose of inhaled corticosteroid, the duration that they're on the inhaled corticosteroid, and the later development of NTM lung disease. And it really is in a dose-dependent fashion. We used to prescribe inhaled corticosteroids routinely for anything that even mimicked asthma, right, without further investigation. And thinking that these were very benign drugs, and we know that there are consequences to anything we prescribe.
Yeah, it reminds me a little bit of in obviously a very different way of having to prescribe opiates. These patients are on steroids and they have been on them for so long, yeah, and they have an obstructive disease, and you're coming to offer removing a medication that symptomatologically probably was helping, and so it's a really tough decision.
It is
very important to make a good diagnosis initially so that they're not on steroids unless they really need it.
Absolutely. This is a more recent study, just to belabor the point. This was 10,000 Korean patients prescribed inhaled corticosteroid, and the covariate adjusted hazard ratio for inhaled corticosteroid and NTM infection was 4. And the length of ICS, the inhaled corticosteroid, increased the adjusted hazard ratio significantly. What about BMI and NTM lung disease? Again, this is data based on 4.3 million patients living in Korea, or people living in Korea. And you can see that there's a real inverse relationship between BMI and the hazard ratio for NTM lung disease, which is one of the reasons that we really talk a lot about nutritional status. BMI is positively correlated with NTM treatment success, and that's why it's important in this particular case. Among 250 patients from Japan, people with a BMI less than 18.5 were less likely to have negative sputum conversion, and in fact, have actual refractory cases. Hence, we emphasize nutrition quite a bit and encourage patients to keep their BMI usually above 20 if possible. And why do we care about treatment refractory disease? Because it's not insignificant. It is associated with poor prognosis over time if we're not able to achieve a microbiologic cure. We know that these patients are not going to do as well over time. Again, this is a large cohort of patients, specifically with MAC. Those in the red line are those who achieved microbiologic cure, and those in the blue line are those who did not.
All right, so we did our, thank you, Colin. So we did our initial workup for our patient. We got PFTs, we got sputum, again, to make sure this is growing again. Then we did the education. We made the referral to pharmacotherapy because a lot of these meds are hard to get or need a lot of education about them. We did the audiology referral. We did ophthalmology referral. And we did the barium esophagram and MDS because the patient was complaining about some reflux. And then we did also sweat chloride testing to see if there's any abnormality. And so just mentioning all these because these take time.
Oh, yes.
And so a lot of times we learn to be proactive. So sometimes somebody comes and they were not sure they need to start treatment immediately, but we're like, okay, let's start the workup because the workup takes months or at least weeks until we're able to have them ready for therapy.
Yes.
What would be great to have within our program, and as Colin described, the importance of BMI is really having nutrition counseling. Patients are very anxious about their diagnosis. They're usually undernourished. And so it's important to have that part of the control. Yeah, yeah. They're in a catabolic state. Psychological evaluation. This disease becomes really kind of the main part of their life, and they know that it's a chronic disease. Having an RN navigator, because these patients have a lot of questions that come and a lot of toxicities. And so having a dedicated RN navigator would be great. And as well as dedicated pharmacy, goes without saying with all the toxicities that we described. Might be needed in certain patients would be a surgical evaluation if they have a localized disease caused by a mycobacterium that's hard to eliminate. Might be a good surgical evaluation. ENT, allergy and immunology referrals in the patient that we described. And as we said, GERD is a big part of the NTM pulmonary disease. And so in certain patients, it might be helpful to have. So let's go back to really our case and what we did. So as we said, patients should never be on just azithromycin. So azithromycin is quasi always and should always be, if possible, accompanied by ethambutol. Ethambutol has some intrinsic activity against MAC, but its main role here is really protecting azithromycin from resistance. And we see that with TB as well. And then rifampin is the third medication. Here we give it 3 times a week because this patient has a nodular bronchiectatic disease and not cavitary disease. So there have been studies showing that there is a non-inferiority of using a 3 times a week treatment rather than using a daily therapy. And there might be some benefit in terms of tolerability of the therapy, and patients like this regimen better than the daily treatment. So now we treated this patient with this treatment that I just mentioned in the previous slide, but the AFB cultures at 6 months remain positive. So which medication below is the best addition to her regimen? I'm going to give like 5 seconds to see if anyone can like unmute themselves or like put it in the chat. We cannot see the chat, unfortunately. So,
so you'll just have, it'll be a rhetorical question.
Yeah, or Annie can like let us know. So
inhaled lipo, amikacin.
All right, perfect.
We like it. We like it.
We like it, and that is the right answer, and that is based on a great study called the Convert, part of the Convert trial, that looked at amikacin liposome inhalation suspension that is used in those patients who did not, or most of them did not clear their AFB cultures, and then these are baseline. They are either received inhaled amikacin or received just a kind of the standard regimen. So continued on the standard regimen or changed or added ALIS basically to their treatment. And you can see here that in those who are just on treatment without the addition of ALIS, there were 6, went up to 9 by 1 month of continuing that treatment. And then for the most part, kind of like no additional. So this is a cumulative number of people who were able to sustain clearance of their culture. In comparison with the dark gray one, you can see that the number significantly increased over time once ALIS was added. And for that, because of that, the guidelines say at 6 months, if the cultures are continue to be positive in MAC, adding ALIS is standard of care at this point.
There are challenges definitely with ALIS, and I'll speak to those very quickly. But we can't underemphasize enough that this was the first ever FDA approved treatment for MAC lung disease. So in that way, it was a milestone, and it's still we use it quite a bit. particularly, well, in our refractory cases, which is the FDA indication, but it is not a walk in the park. There are a number of treatment emergent adverse events that are of particular interest, and I've highlighted a few of these. In particular, tinnitus, dizziness, which we see with aminoglycosides in general, that can be treatment limiting. Dysphonia is extremely common with these folks. They do develop hoarseness. I counsel patients, look, you're probably going to develop it. It is usually self-limited. Cough, dyspnea, and hemoptysis are also pretty common. You can see in the curves to the right, the percentage of patients with those symptoms. Usually by month 2, they tend to improve and they go down to sort of the baseline or the background in the study. But sometimes, we need to we need to limit treatment because of these emergent effects.
So for how long do we treat? And that's the question that we ask ourselves. And usually the AFB sputum culture conversion date really determines after that, the duration of therapy. So assuming somebody is clinically improving and they had a first negative AFB culture in March of 2026, then they should be continued on treatment till March of 2027. That's usually what the guidelines say. Now, a lot of times, as usual, patients cannot give us more sputa. They are refusing to get a new bronchoscopy, or it's hard to get it. So sometimes we have to make a decision, kind of educated decision, and say we'll treat for 18 months, kind of total therapy, because we assume that they have cleared their culture if they are clinically improving and their CT scans are improving. And it's always a shared decision making because patients sometimes just cannot tolerate the treatment for too long.
And you can probably tell we're very excited about this subject, so much so that each slide, which was supposed to take 1 minute, of course, has ended up taking multiple minutes because we could talk for hours about this. But we did want to brush on case 2 as well. So this is a 66-year-old man with emphysema to COPD, tobacco abuse, who was referred to ID clinic for possible MTB. He was recently hospitalized for hemoptysis, recurring low-grade fever, anorexia, placed on airborne precautions, and started on RIPE therapy empirically. 3 AFB sputa were negative, smear negative, and the MTB PCR probes were also negative. He describes a 5-month history course of minor hemoptysis, insidious weight loss of around 15 pounds, worsening breathlessness on exertion, and nightly drenching night sweats, as well as low-grade fevers. No recent travel or infectious exposures. He's a retired airline mechanic for Delta and lives at home with his wife, and he has a 50-pack year smoking history. And this is, just sort of his CT. So you can see for all intents and purposes here, this looks like active TB. I can understand why he was placed on airborne precautions. So you have a left upper lobe thick-walled cavitary lesion on a background of emphysematous lung disease. You can see that there are sort of these satellite lesions of nodularity and tree and bud nodularity. It is a thick-walled cavitary lesion, explaining his hemoptysis.
Yeah. So perfect. So this patient, we're not going to go through everything just because of time restraints, but this patient grew Mycobacterium abscessus. So they grew Mycobacterium abscessus, and you can see kind of how this patient. So this is the fibrocavitary disease that kind of Colin was talking about and kind of describing. I don't know if you wanted to say something about that.
Yeah. So just very quickly, so there are 2 main disease phenotypes that we see with NTM lung disease, and this is the typical fibrocavitary disease phenotype. So in contrast to the nodular bronchiectatic phenotype. These patients tend to have COPD, emphysema. They tend to have a history of smoking, tend to affect men over women, upper lobe predominant, and prior structural lung disease. They present sort of in weeks to months, so sort of more of a subacute sort of presentation. You want to talk about subspecies?
Yeah, so here kind of the same when we send it to National Jewish. Again, Grady sends it to Quest, so it's a bit different. But here it's very important. The one thing I want you to take from this is when it grows Mycobacterium abscessus, the first question should be, what's the subspecies? Because National Jewish will give you the subspecies, and then based on that, you can kind of like predict the resistance pattern. You will also receive results that are related to the to the resistance pattern, because Mycobacterium abscessus, subspecies abscessus, which is the most common one we see, usually is resistant to azithromycin. If we want to take one thing from susceptibility talk today, is that it's good to be azithromycin susceptible. It's bad to be azithromycin resistant. And you can see here that in the study where you can see that a sustained culture conversion without relapse is only 23% in abscessus subspecies abscessus, whereas in another Mycobacterium abscessus, which subspecies Macilliense, that is usually susceptible to azithromycin, the sustained culture conversion is up to 84%. So you can see the difference is huge just based on what subspecies we're dealing with and if it's azithro resistance or not. And so anything to say?
No,
Yeah.
we can go through these just in the interest of time.
So yeah, interest of time, just kind of like showing the same genetics here. Looking at azithro, I just want to highlight the fact that it's going to look at the beginning, and that's what a lot of microlabs make the mistake, is to give us azithromycin susceptibility with an incubation that's short, and then with that, it looks like as if it's susceptible, but then very important to always, when you look at abscesses, to look at azithromycin at 14-day incubation, and you'll see here where it becomes resistance and should not be used as an active agent.
We probably should not talk about some of our outside other health systems outside of Emory in the region, but you will oftentimes get referrals to the ID clinic or to our clinic where the patient has been started on macrolides because the initial susceptibilities that within 14 days showed that it was macrolide susceptible. But if you hold it over for 14 days, it will become very resistant.
Perfect. So this is a severely sick patient with Mycobacterium abscessus. So this patient actually needs to be on IV therapy as initiation therapy. And it goes without saying that IV therapy means this patient needs a PICC line placement, needs an ongoing care for at least 3-4 months of IV therapy. They will have ototoxicity and nephrotoxicity with aminoglycosides. They will need weekly labs, and they will need monthly audiometries. So what this patient needs to be on, and I'm not going to go, you can review these slides, but really the induction therapy is usually 3 to 4 medications, including 2 IV therapies and 1 pill. Clofazimine has synergistic effect with amikacin, and you can see it in the susceptibilities here with clofazimine, amikacin. But also then you're going to go to the consolidation phase, which ends the same way as all NTM at 12 months from the first negative culture. Drug toxicity monitoring, I'm not going to read all of those again because of time restraints, but, a lot of labs, a lot of referrals, a lot of monitoring that happens. Clofazimine also will not go through the details of this slide, but this is a medication that our clinic and our program has expanded access, multi-patient access to it. And so we use this medication quite frequently because of its synergistic effect, because its susceptibility and low risk of resistance. It's a medication used to treat Hansen's disease and also to treat multi-drug resistant TB sometimes. And so a very important medication that we have access to here in our clinic.
And it's also very well tolerated as well. The only main side effect is skin darkening and also the QTC that we need to, we just need to be mindful of that. I also don't want to underplay the role of thoracic surgery for any thoracic surgery colleagues out there who are listening in the well-selected patient. If there is a refractory disease, recurrent hemoptysis, particularly if the disease is limited to one lobe or a lung, it can be curative. We have sent these patients on for resection successfully. Some newer treatment considerations. It's an exciting time for both bronchiectasis and NTM. In 2025, we saw our first ever FDA approval of a medication specifically for non-CF bronchiectasis, brensocatib. We have other ones on the heels that are in phase 3 trials. We're participating in all of those. We recently finished a trial right here at Emory that my colleagues and I collaborated on, evaluating highly effective modulator therapy in non-CF bronchiectasis. And so we're looking forward to publishing that. Also, there are a couple of other things for abscessus in particular, phage therapy, newer novel antibiotics, as well as dual beta-lactam therapy. And the reason, I hope that we've, sort of belabored a lot of this point is that these are exciting times for bronchiectasis and NTM patient care and research. Our patient population is growing. That curve over on the right is the Emory bronchiectasis and NTM program. You can see that it's really skyrocketed, particularly following COVID. It is going to continue to grow. Our clinical and translational research program also is growing rapidly. We realize there is a need to educate trainees to better meet the needs of bronchiectasis and NTM patients in the region and beyond, and to reach patients in underserved and rural communities. Right now, we're not capturing those as well as we should. Also expanding our community outreach and education to better educate our community healthcare providers. There is support available. So through NTM-IR, through the Bronchiectasis and NTM Association, and if the patient has primary ciliary dyskinesia, through the PCD Foundation as well.
Yeah, in summary, so the NTM pulmonary disease, as you probably have seen now, is a complex process with significant downstream effects in terms of disease progression or medication toxicity. So whatever you decide in terms of management, it's a comprehensive multidisciplinary care is essential to improve patient outcomes. And this ID Pulmonary partnership is really a step in that direction. If you're interested in a neglected field, please join our program and join our clinic. You're welcome, and especially for trainees to come here. Dr. Shimura and Dr. Samaha last week joined me from residents. IM residents joined us in clinic, and we're more than happy to have them again and have other residents and fellows as well with us.
Absolutely, I'd like to echo that as well.
Thank you both for this excellent talk. We do have time for Dr. Susan Ray had one question in the chat going back to the inhaled liposomal amikacin, asking, could you talk about how specific that product is and why we can't just aerosolize regular amikacin and have a whole special delivery setup?
A really good question. So I would argue first off that the liposomal formulation is the only one that has been evaluated in the largest clinical trial ever for NTM lung disease. So we know it's effective. As part of that trial, they did do animal models, and they sacrificed the animals just to sort of see the concentration in the alveolar macrophages. The liposomal formulations was many, many more times concentrated in the alveolar macrophages, where indeed a lot of this infection lives, than the non-liposomal free amikacin. So I would caution that that we know one of them works specifically for NTMs. We have no reason to think that it wouldn't work for abscessus as well. And in fact, we do use it, particularly during the consolidation phase of treatment for abscessus. But we know that for MAC, particularly if it's aminoglycoside susceptible, it is very effective.
All right. Well, thank you everyone for being here. Thanks to our incredible speakers, and we hope you have a great rest of your afternoon. All right.
Thank you everyone for joining.
Thank you.